Hello, this is Mirrakhimov speaking. I'm one of the cardiac anesthesiologists at the University of Kentucky, and today we'll be talking about the role of clonidine and dexmedetomidine in anesthesiology and critical care medicine practices. I have no conflict of interest for this presentation. Please take a moment to review the disclaimer for this presentation. Our agenda for today is to review the history of clonidine and dexmedetomidine development, understand the pharmacology and mechanism of action, review the clinical uses in anesthesiology and critical care medicine, as well as understand some of the adverse effects and complications which can be a result of dexmedetomidine and clonidine use. Here we will review the timeline of clonidine development. It was first developed in 1961 as nasal decongestant. In 1966, it was found to be useful in the management of hypertension, and the first use in anesthesia practice was described in 1978. Outside of anesthesiology and critical care medicine practices, clonidine is used in the management of hypertension, attention deficit hyperactivity disorder, Tourette syndrome, and is used in the clonidine suppression test, which is sometimes used in the workup and diagnosis of suspected pheochromocytoma. So what about the timeline of dexmedetomidine? It was first developed in 1990. 9 years later, it was approved for sedation in mechanically ventilated ICU patients, and in 2008, it was approved for the use in therapeutic arena and anesthesiology practice. Let's continue talking about the pharmacology of clonidine and dexmedetomidine. Most of these medications act on alpha-2 receptors and imidazoline receptors. On this picture, you see a synaptic vesicle containing norepinephrine. Clonidine and dexmedetomidine activate presynaptic alpha-2 receptors, which via negative feedback leads to reduction of norepinephrine release from the synaptic vesicle. Let's continue. Alpha-2 stimulation in the pons region known as locus coeruleus leads to sedation and anxiolysis. Presynaptic and postsynaptic alpha-2 agonism at the level of the spinal cord leads to analgesic effects via decrease in norepinephrine, substance P, and glutamate. Clonidine and dexmedetomidine also activate alpha-2 receptors in the peripheral nervous system and lead to analgesic effect via reduction in substance P. Let's review relevant receptors such as alpha-2A, alpha-2B, alpha-2C, imidazoline 1, 2, and 3. Alpha-2A and imidazoline 1 receptors are very similar in terms of the location and action. The effects of those receptors lead to reduction in sympathetic output, sedation, and analgesia. Alpha-2B receptors are located predominantly in vascular smooth muscle and lead to vasoconstriction. Alpha-2C receptors are located in the prefrontal cortex and may play a role in attention and memory formation. Imidazoline 2 receptors are located in various parts of the brain and are believed to modulate pain. Imidazoline 3 receptors are located in the pancreas and are believed to play a role in insulin secretion. Let's talk and discuss clonidine. It is an alpha-2 agonist. The selectivity for alpha-2 receptors compared to alpha-1 receptors is approximately 200 to 1. It has a good oral bioavailability. It is metabolized predominantly by the liver and minimally excreted via kidney and renal systems. The half-life is approximately 12 hours and can be used and administered via oral, IV, uraxial, and transdermal routes. Let's go through some of the expected effects of clonidine administration. At the level of the CNS, it leads to sedation, analgesia, and it reduces the requirements of anesthetic agents. It also decreases cerebral blood flow and cerebral metabolic rate. At the ocular level, it reduces intraocular pressure. It can lead to hypertension, especially with IV administration, because of alpha-2b receptor activation, and alpha-1 receptor activation. Remember that with IV dose, these peripheral receptors such as alpha-2b and alpha-1 are typically activated before the medication reaches the brainstem. With prolonged infusions and continuous infusions, it commonly leads to hypotension. Bradycardia is also an expected effect of clonidine administration. It minimally reduces respiratory drive when used alone, and it promotes diuresis. Clonidine anesthesia in ICU practices is typically used as an adjunct to regional anesthesia, both in regional peripheral nerve blocks as well as in neuraxial procedures. It is also quite often used in patients who have refractory pain, such as chronic cancer pain. Outside of the United States, it is typically used as a sedative in the ICU and also can be used in the withdrawal management, such as alcohol and opiate withdrawal, for example. Clonidine is also associated with decreased shivering and reduced emergency delirium and agitation. So what about clonidine and regional anesthesia? It prolongs the sensory block. However, it is unclear if it does so for motor block. It reduces opiate requirements. It can lead to sedation and other side effects because of absorption. The typical dose for intrathecal route is 1 to 2 micrograms per kilogram of preservative-free or PF version of clonidine, and the dose is approximately 150 micrograms for peripheral nerve blocks. Again, these doses are for adult population. Let's review the adverse effects of clonidine. As a sedative, it can lead to drowsiness, which sometimes can be undesired, hypotension and hypertension. Hypertension is typically associated with IV administration, bradycardia and atrioventricular blocks, rebound hypertension after withdrawal of clonidine, and dry mouths. Contraindications to clonidine include hypotension, symptomatic bradycardia, and advanced atrioventricular blocks. Now it is time for us to discuss dexmedetomidine. It is approximately 8 times more specific for alpha-2 receptors compared to clonidine. It is approved for less than 24-hour sedation in the ICU and also as an adjunct for general anesthesia. Again, it is quite often used as off-label medication in regional, neuraxial, and pain management. It can also be used to manage intoxications, such as, for example, cocaine, agitation, and medication withdrawal, such as alcohol and opioid. Dexmedetomidine, if used orally, undergoes extensive first-pass metabolism in the liver and thus is not very effective via oral and enteral routes. Liver plays a major role in the metabolism of dexmedetomidine. About less than 1% of the medication is excreted via kidneys. Consider dose reduction in patients who have advanced liver disease. Dexmedetomidine can be given initially as a bolus of approximately 0.5 to 1 micrograms per kilogram. It is recommended to give this bolus over at least 5 to 10 minutes to mitigate some of the hemodynamic responses. It can also be given as a continuous infusion of approximately 0.2 to 0.7 micrograms per kilogram per hour. Prolonged use, beyond 5 days potentially, may be associated with withdrawal symptoms if this medication is abruptly discontinued, such as hypertension, tachycardia, and agitation. Bolus dosing of dexmedetomidine may lead to hypertension and bradycardia via activation of peripheral alpha-2b receptors. Continuous infusion of this medication is associated with bradycardia and decreased blood pressure of approximately 20% below baseline levels. The onset of action of dexmedetomidine after intravenous administration is in approximately 5 to 10 minutes, and the peak effect occurs in about 15 to 30 minutes. It has sedative and anxiolytic properties, as well as modest analgesic effects. The sedation resembles a sleep-like state. Dexmedetomidine is an unreliable amnestic agent, which can be favorable or desired, for example, such as in cases of cesarean section, or sometimes undesirable when you need to ensure amnesia. It is associated with decreased postoperative delirium states and may blunt the stress response to surgery. Other than IV formulation, it can also be used intranasally as a part of neuraxial and peripheral nerve blocks. Let's discuss the organ effects of dexmedetomidine. We'll start with the central nervous system. It leads to a sleep-like sedation, anxiolysis, and modus analgesia. It is associated with decreased anesthetic requirements, reduced cerebral metabolic rate, cerebral blood flow, intracranial and intraocular pressures. Similarly to clonidine, it leads to reduced shivering threshold. At the level of cardiovascular system, it can lead to both hypertension and hypotension. Bradycardia is a possible effect. Dexmedetomidine has no direct effect on cardiac performance, though. It is associated with minimal to no respiratory depression when used alone, can lead to diuresis, and reduce the secretion of insulin and salivation as well. So what about the duration of dexmedetomidine effects? It is variable, and on average ranges from about an hour to 4 hours. On this graph you see a context-sensitive half-time relevant for dexmedetomidine. Just to remind ourselves, the context-sensitive half-time is the amount of time needed for the plasma concentration of medication to drop by 50% after the stop of the infusion of this medication. Side effects of dexmedetomidine are similar to clonidine and can be expected from its mechanism of action. It can lead to hypo and hypertension, bradycardia and heart block, and in ICU population sometimes can lead to fever and febrile responses. So in summary, alpha-2 agonists play a major role in anesthesia, such as adjuncts to general, neuraxial, and regional techniques. In critical care medicine, they are often used as a part of sedation. These medications lead to sedation, anxiolysis, and some analgesia. When used in isolation, they typically do not lead to major or clinically significant respiratory depression. Again, it is important for us to remember that alpha-2 agonists do not have a reliable amnestic response. And side effects include hemodynamic abnormalities such as hypo and hypertension, bradycardia. In an ICU population, it can sometimes lead to a fever and febrile response. This concludes this lecture. I want to thank you for your attention. If you have any questions, please feel free to email me on the email address provided on this slide. Thank you and good luck.